It's my pleasure to introduce Dr. Charles Thorne, who is the Chief of the Department of Plastic Surgery at Lenox Hill, Northwell Health. He's also the founder and chairman of NextGenFace Foundation. He's a world expert on microtia repair, and we're fortunate to have him today give us a lecture on total ear reconstruction. Dr. Thorne?
So my topic is ear reconstruction. It's a little bit easier to retrace your steps on cross-country skis, as I'm doing here, than it is to retrace a 30-year career dedicated to ear reconstruction in 20 minutes, but that's what I'll try to do this morning. I'd first like to say that taking care of these patients, I think, has been the most rewarding part of my entire career. And following the patients over decades as they send me pictures of their graduations and weddings and so on is really remarkable. This child was born without both ears and is someone I've kept in touch with for many years. This is a patient who made a Christmas card out of her before and immediately post-op after ear reconstruction. What we're trying to avoid is this situation. This is a patient who underwent an ear reconstruction with a complication, followed by another operation and a complication, followed by more of the same, and then came to me. And at this point, obviously, it's extremely difficult to help him as much as we'd like to. So, although we're not perfect, we try to get things as good as we can the first time to avoid this type of situation. So who needs ear reconstruction? Patients come to us having been born without an ear, or after trauma, or after having an ear removed surgically for a malignancy. We'll start talking about those patients who have microtia, that is, who were born in this way, and are primary patients, meaning they've had no surgery previously. Now, not all cases of microtia are the same. For example, there might be a patient who has sort of 2/3 of an ear and part of an ear and almost no ear with just a little nubbin and a hairline that's in the wrong place. Or a patient that, like this, who has a remnant that's totally in the wrong place, has a low hairline, and has significant soft tissue and skeletal underdevelopment and facial asymmetry. So to talk about these patients as if their ear reconstruction is the same is obviously totally naive. A word about hearing. Almost all patients with microtia have oral atresia, that is, they have no ear canal, meaning they're functionally deaf on that side. This CT scan shows a normal skull on your left, and you see there's an ear canal. There's a hole in the skull connecting the external ear with the middle and inner ear, whereas on a patient with microtia, there's no such canal. There's no opening in the bone, and the external ear that we create has no connection, unless we make one, to the middle and inner ear. The good news is that 90% of the time microtia is unilateral, and the patients have normal hearing in the opposite side. And those patients do very well. They do have some problems with localization and discrimination of sounds, but overall, because they have normal hearing in one side, they do very well. Bilateral microtia is a totally different beast. It occurs only 10% of the time, but because it involves both sides, those patients have no functional hearing, and they require a hearing aid at birth in order to have sufficient hearing to develop speech. This is the type of hearing aid that the patients are given in infancy. And then later on, the hearing can be restored either surgically or with a bone-anchored hearing aid. We don't have time to go into this in detail, but schematically, this is the surgical reconstruction of the canal, which involves drilling a hole in the bone and creating an eardrum and so on. And then this is the one of the current editions of the bone-anchored hearing aid, which have gotten so good and so light and so small that they've almost completely replaced the surgical repair. But let's talk about how we do the actual surgical reconstruction of the external ear. One of the questions that comes up is when's the best age to do it? It depends on a lot of issues and when the patient presents and so on, but if we really had our choice, we do it at age 10 years. That's when the opposite ear is about 95% grown and the rib cartilage is of adequate size to create a good framework. Which brings up the second question is what's the best material to use? There are two possibilities. One, on your right, is some kind of artificial material. This is porous polyethylene. And on the left is the type that we prefer, which is a framework made out of the patient's own cartilage. And in my experience, the complication rate over the long term is lower if we can get a decent reconstruction using the patient's own tissue. So to divide the reconstruction into the cartilage component and the skin component, we'll start with the cartilage. And we decide what size ear would be ideal, usually by tracing the opposite side, and then subtract in our minds the thickness of the skin in order to decide exactly what size, shape, cartilage framework would be required to create, once the skin is draped over it, an auricle of the appropriate size and detail. And then cartilage is harvested from the chest, and the details of the ear are carved into the base. And then pieces are added to that base to create more detail. I think you can see there's an additional Y-shaped piece that's been added on top of the framework to begin to create some of the details of the ear. And then the helical rim is attached. You see here being attached with a series of sutures. And then the tragus, anti-tragus piece are attached, and additional support pieces on the deep surface of the framework in order to create a framework that we then need to insert into some kind of pocket in the skin. Which brings us to how we manage the skin. And frankly, when you become somewhat experienced with this technique, the cartilage framework is probably the easiest part. The more difficult part is how you manage the soft tissue and how we get that framework covered with healthy skin. One issue which is less trivial than you might think is where we're going to put the ear. On the patient on the left, it's pretty simple because that patient has a symmetrical face and there's one obvious place for that ear to go. Not so with the patient on the right. So this patient on the left, it's pretty obvious where the ear needs to go. This patient, though, if we were to measure from the corner of the eye to the ear on his left side, the more normal side, and then put the ear the same distance from the corner of the eye, it would look like it's on the back of his head because the entire size of the face is smaller. On the other hand, if we put it where the remnant is, that would be absolutely not correct either. So various compromises have to be made about where we decide to even put the ear, and then we have to decide exactly what angle to put it. If it's too angulated, for example, you can see immediately that doesn't look right. So I'm just making the point that just the basic decision about where you put the ear, it requires a lot of thought and planning. And then there's a whole subject of the various incisions required to create the pocket, which again I won't go into a lot of detail, but I'll show an example. Here's a patient where we've decided we want a 60 millimeter ear. We want it to come down as far as this point because that's where the other lobule on the patient's opposite side comes to. And this is the angle that we want the ultimate auricle to be. So the lobule, which as you can see here is vertically oriented, is then rotated down into position so that it comes down to that line that we had originally intended the ear to come to. and a pocket is dissected. Here's a view of the inside of the pocket. And then the framework is put in with a couple of drains, and this is how it looks immediately at the end of the procedure. Then 6 months later, we've got to elevate the ear. You can see if we go back here that this ear is sort of stuck to the head. There's no space behind it. So 6 months later, we do an operation to actually elevate the ear. Schematically, you can see here that a piece of cartilage has been wedged in behind the ear, covered with some tissue, and then a skin graft has been used to line that sulcus behind the ear. Then here's a patient who 1 week previously had had that procedure. And the rear view showing that skin graft and a sulcus behind the ear, so the patient's ear has some degree of projection and he or she can wear glasses. So how good does it look? Well, honestly, it doesn't look as good as an absolutely normal ear, and at least when I do it. And the goal is to try to make it look acceptable or look like a normal ear from conversational distance. If you actually try to move the ear around, I don't think it'll fool anybody, but the idea is to give kids, and eventually whatever age they happen to be, the ability so that in normal conversation it's not apparent that they had any issue at birth. And here are just a few examples. This shows a patient who had a right ear reconstruction, and it's, again, it seems trivial, but to get the earrings at approximately the same level is of tremendous importance to some patients. Here's another example of a before and after, and then it's particularly gratifying when the patient likes the ear enough to go ahead and get the ear pierced and show it off in real life. They don't all look quite that good. Here's just a few other examples. It's particularly challenging when the patient has a canal or a remnant of a canal, because sometimes we have to try to move the canal. The ear has to go in the correct position regardless of where the canal is, so that's another variable that has to be addressed. And then just briefly a word about secondary reconstruction, that is those patients who might have had an operation that didn't go well. Here's such an example. She had had ear reconstruction, she was not happy with it, and we had to take everything out, take new cartilage from the opposite chest, start over again, and we're able to get to this point. But secondary reconstruction is, as I had mentioned earlier, is much more difficult, and we'd prefer to avoid this situation if we possibly can. I wanted to mention how we handle a more difficult patient, just to emphasize the need for coordinated team care. So I showed this patient previously, but he's going to need surgery on his mandible, on his lower jaw at an early age. He's going to need augmentation of the soft tissue where that depression is. He's going to need an ear reconstruction. He's going to need definitive jaw surgery later on. And we don't always do it in this order, but as a general rule, this is how we organize things. So we all need to know, as parts of the team, what each other is doing and when we're going to do it and how each operation affects that which the next person is going to do. So just to run through this as an example, the first step is frequently an operation on the lower jaw. So we call somebody like Jim Bradley, who will speak next, to do a procedure on the jaw where a device is inserted to lengthen the mandible. And then at some point, the patient needs augmentation of the soft tissue on the cheek. Then we'd call someone on the team like Dr. Lerman or Dr. Deck to perform a procedure where soft tissue from another part of the body in the form of a microvascular transfer is buried under the skin and contoured as carefully as possible to replace the missing tissue. Here's a patient. The operation was done by one of our previous colleagues, Dr. John Siebert. You see the deficiency on her right and the post-op result. By the way, she recently got married and had a baby and sent us a picture, and once again, enormously gratifying to take care of people like this. and then the ear reconstruction, which I mentioned, and then eventually definitive jaw surgery. And this is when somebody like Dr. Hirsch would evaluate the patient preoperatively using the CT scan and using virtual surgical planning, decide where to move the lower jaw, where to move the upper jaw, and then postoperatively the CT scan shows that the facial symmetry has been restored more or less as the plan had dictated. And the point I'm just trying to make is how we all have to work together, because these patients need several operations over the course of a lifetime, and it helps that we all know each other and know how we work, and it helps us, I think, work as a team and deliver the best possible result. I mentioned some patients need an ear reconstruction because of previous trauma. Here's a patient who'd lost half of an ear because of a dog bite. So a tracing is made of the normal ear, and we figure out exactly what's missing and try to replace that with appropriate pieces of rib cartilage. And so then here the patient is with the appropriate details, so the size and shape of the ear are restored as much as possible. And just another quick example, another pit bull bite, the big amount of ear missing in the postoperative result. This is gory, but this is a patient who was a pedestrian on the west side of Manhattan, run over by a car, and the entire ear was lost, and then the post-op reconstruction. And finally, I just wanted to mention those cases where patients have ears removed because of surgery, and this is obviously usually adults, usually older adults, and this is you heard from Dr. Brecht earlier today. Well, he does a lot more than nasoalveolar molding. Here's one of his patients who had surgery for a malignancy, lost his ear, as well as a lot of surrounding tissue, was also irradiated, and Dr. Brecht made him a prosthesis and designed a mechanism to retain that prosthesis. And here's the patient post-operatively, where you'd be hard-pressed at conversational distance to know that anything was missing at all. Just a couple words about the future. I've been working with Dr. Jason Spector at Cornell and a company to attempt to print cartilage frameworks to avoid having to take the cartilage from the rib. And the problem is that it takes about 250 million cartilage cells to make an ear framework, and it's only recently that the scientists have figured out how to do that in a practical amount of time by mixing cartilage cells and mesenchymal stem cells to make a boatload of cartilage cells, enough to actually print a cartilage framework. And the way this would work, and the way it works in the laboratory, is that a mold, computer-generated mold, is made of the desired ear shape. So here is an ear frame, a cartilage framework being printed using a slurry of cartilage cells to create, theoretically, precisely the framework that we would need to create the ear of the dimensions that we require. Hopefully we're not too far away from a day when we can create patient-specific ear frameworks by biopsying a piece of cartilage, mixing it with stem cells, printing a framework that's precisely the right size, and implanting in the patient. So here's a patient who sent me a card. Thank you for the wonderful ear. Once again, thank you for listening.